Today we're going to be doing an introduction to motivational interviewing in 3 modules. My name's Nikki Cockern. I'm a psychologist here at Wayne State University, and I'm also working for Behavior Change Consulting. So our first module is an overview of motivational interviewing. So who are we? We're Behavior Change Consulting. We focus on evidence-based communication. We're also a diverse group of trainers from different ethnic, socioeconomic, and educational backgrounds. And we have a unique blend of academic rigor and community-based real-world practice. And we're also members of the Motivational Interviewing Network of Trainers. We have a few books that are out. Actually, Dr. Sylvie Nar has some books that are motivational interviewing with adolescents and young adults. And one that's just hot off the presses is Motivational Interviewing and CBT, or Cognitive Behavioral Therapy, combining strategies for maximum effectiveness. We've been fortunate enough to utilize motivational interviewing strategies in several of our clinics on campus, and we found some really good success with our programs. So for our introduction today, we're going to look at Module 1 as an overview of motivational interviewing. Module 2, we'll be looking at motivational language and how to actually practice some of the things that we'll be talking about. And Module 3 are the processes of motivational interviewing encounters. Okay, so for Module 1 objectives, we're going to, the overview. Objective 1, is to understand why behavior change is hard. Objective 2 is to learn about motivational interviewing as a framework of effective communication. And Objective 3 is to appreciate the spirit of motivational interviewing. So when we think about behavior change, you would think that hangovers, damaged relationships, an auto crash, and memory blackouts would be enough to convince someone to stop drinking. Or developing type 2 diabetes, heart problems, fatigue, and difficulty breathing would encourage obese individuals to exercise and maintain a balanced diet. Similarly, threats of blindness, amputations, and other complications from uncontrolled diabetes would be enough to improve adherence to physician recommendations, just on GP. And also, being diagnosed with HIV would make a person stop having unprotected sex. So we would think that all of these things would happen naturally just because of the behaviors and the consequences of those behaviors. However, what do we do to try to make people change? We want to give them insight. If you can just make people see what they're doing, then they'll change. You can just make them, if you give them knowledge, if people just know enough, then they will change. And if you give them skills, if you can just teach people how to change, then they will do it, just automatically. And if you give them hell, if you can make people feel bad enough or afraid enough, then that's going to make them change. But we know that that doesn't always work. So just think about yourselves. Have you ever made the same goal more than once? Have you ever tried to quit smoking or stop yelling or exercise more or keep your home organized or stop procrastinating? You know, if you've given, make the same New Year's resolution every year, oh, I'm going to do this. Have you ever been told by your physician to do something that you weren't ready to do? Lose weight, take vitamins, take medications, have surgery, exercise? Or have you ever told someone that they shouldn't be in a relationship that you thought was damaging? And has anyone ever given you unsolicited advice and expected you to follow it even if you didn't agree with it? So if any of those things have happened to us, we just think about it. Change is hard. Who really wants to change? A person who truly welcomes a change is a baby with a full diaper. And truthfully, I thought that was true until I met my nephew, who really didn't care if he had a full diaper or not. But change in general is really difficult for us. I mean, if you think about it, even when you have, strep or something, and you get antibiotics and they tell you to take it for 14 days, how many of us take it for the full 14 days? We get to day 10, we're having some gut issues, we're having some other things, we feel better, oh, I don't need that. So even in the face of a short-term duration, it's hard to change. So when we think about what promotes behavior change, we have relatedness. So people internalize from those who are kind and caring. And they tend to reject advice and values from those who are harsh and controlling. If we think about the best teacher we've ever had versus the worst teacher we've ever had, think about the qualities that made that teacher the worst. And a lot of times those are people who said things that were harsh and controlling and did things in ways that made us feel badly, and we didn't want to internalize any of those things, versus our good teachers. The other things that promote behavior change are competence. People internalize when they feel hopeful and confident. When you feel that you can do something and that you have the ability to do that, you're more likely to do it, versus rejecting when you feel insecure and helpless. So if someone's asking you to climb Mount Everest and you have no climbing skills or don't think that that's something that you could do, you're going to feel that this is not something that I'm going to try to attempt, even though it may be suggested or recommended. Another thing that promotes behavior change is autonomy. People internalize when they feel that they have a choice versus when they feel forced and constrained. So when you're mandated to do something versus when you have a choice to do something, you're more likely to internalize when you feel you have a choice. It doesn't mean that you necessarily reject things when you're forced, but sometimes that's a barrier. And what we like to do is communication to promote change. As a provider, you have an opportunity to make every interaction count. Providers are often told what to do, but not how to do it in a way that promotes behavior change. Usually we're just given instructions to just do this, do this, do this, do this, and that should be good enough for our patients. But clinical guidelines define the content of assessment and interventions, but not the process. For instance, what language to use or what communication skills are most effective in doing these assessments and implementing these interventions. So what we'll talk about today is how motivational interviewing is different and how you can use that to increase, ideally, the interactions that you have with your patients. So motivational interviewing for effective communication. The simple definition of what MI is a collaborative conversation style for strengthening a person's own motivation and commitment to change. And this is from Steve Rolnick and Bill Miller in 2013. A more complex definition is a collaborative and goal-oriented communication with paying particular attention to the person's language of change. And it's designed to strengthen a person's motivation for and commitment to a specific goal. So it's not just random. And why is MI popular? Well, for many reasons. But there's over 300 studies across multiple populations and health behaviors that use motivational interviewing. There's multiple meta-analyses. It's most effective as a precursor intervention, but it also in terms of very brief interactions to boost motivation, as well as longer treatments. It's also popular because it improves provider confidence and reduces burnout often. What's really nice about MI is that it's flexible. So the research evidence of efficacy, it's across behavior. So it could be substance use, smoking, preventative care, adherence to medications, risk reduction, nutrition, physical activity, among a few behaviors that motivational interviewing has been used. And it's across disciplines. So you don't have to be a physician or a psychologist or a social worker. You can also be a community health worker. You can be a physical therapist. You can be a dentist. You can be a pharmacist. There are many disciplines. It's not just discipline specific or practitioner specific. And MI, it can be done in a variety of settings. It can be done in a medical setting. It can be done in clinic. It could also be done in social service agencies. It can be done in the field, in the community, in someone's home. It can even be done on the telephone or via text messages. So we've done a lot of different, there's a lot of different settings where you can use MI, which have also been effective. There's a cultural diversity and MI. Motivational Interviewing Network of Trainers, which is the MINT. It represents more than 30 languages. So MI is international. The evidence of increased effectiveness among ethnic minorities. And here's the citation. So MI has been used in a variety of countries around the world and in a variety of different languages, and also with a variety of different ethnic groups, minorities also. So let's talk about the elements of motivational interviewing. So we have this, in the middle, we have MI, and then we have the spirit of MI, which is a big portion of motivational interviewing. We have change talk, which is what the things that we're listening for to help people change behavior. We have MI skills, which we'll utilize to encourage change talk. And then we have the 4 MI processes. And we'll talk about each one of those in this particular module. So for MI spirit. MI spirit, MI with someone is like entering their home. One should enter with respect, interest, and kindness, affirm what is good, and refrain from providing unsolicited advice and rearranging their furniture. And this was a quote given by an Alaskan elder who's after an MI workshop when he was asked for reflections of what he gleaned from the workshop. So when we think about spirit, there are 4 components. We think about partnership, acceptance of where the person is, compassion, and evocation. And we'll talk about each one of these points. And just so that you know, without the spirit in MI, it's like having the words or the skills, but no music, which is a spirit. So spirit provides the flow, the comfort, and rapport building in an interaction. So spirit is a major tenet for motivational interviewing. So when we think about the writing reflex and rearranging furniture without permission, these are some of the things that we'll think about. You know, because we're all in helping professions, we want people to be healthier and to do better and to, you know, have things go well for them. But we think about this reflex that we have about, I think you should. So these might be statements that someone says to write something. And the counter response might be, well, that won't work from a person. You really have to. Well, Uncle George did fine. You will feel better if, well, I feel fine now, would be a response potentially. You can do it. No, I can't. So these might be statements that someone says to, like, just to help, you know, them see that this is what we want for them and that you really can do this. But there can be responses that the person gives that they feel that they can't, or they have reasons on why they couldn't. And this is what we mean by rearranging their furniture, particularly without permission. When we think about, so let me just go back for a second. So when we think about MI spirit, we think of PACE. So we have partnership, acceptance, compassion, and evocation. And all of these, we love acronyms, so this is PACE for us. So when we think about partnership, we feel like we're sharing power. I have expertise in something, and our patient or our client has expertise in themselves, and they have an expertise in their lives. So we want to utilize that and share both, you know, our information and recognize that we both have experience in our own areas, and how can we be helpful to the other person. So this is not something that we're doing as I'm telling you what you need to do just for the sake of doing it, and you have no say in what happens. So it's more of a partnership. And when we think about acceptance, there are some various features. So there's affirmation, autonomy, and accurate empathy. Acceptance is a concept that encompasses all of these aspects. So autonomy is allowing the client to be empowered to make their own decisions regarding change. So it really is up to them. As much as we might want to make someone do something, it's truly their decision. And unless we're willing to have them move in our house and we are then, taking charge of them to make sure that they do it, it really is on them. And we have to be able to ideally empower that, but support it too, even if it's not something that we want them to do. We want to think about accurate empathy, which is striving to understand and reflecting the issues from the client's perspective. So if we can understand what's going on for them, then we might have some suggestions on how things could be different. And then affirmations, we want to recognize and describe the client's strengths and values. So even if it's someone who's shown up, just finally shows up to clinic after missing for several visits, you might say, well, today you've decided to take care of yourself. You're really determined. Even though you had to take 3 buses and even though you had to go through all of these challenges, you made it a point to show up here. So you're affirming their strengths and their values. When you're dedicated, when you decide that you want to do something, you go forth and do that. And you can do that in a way that's not cheesy. And really what we want to do is value each client or each patient as a worthy human being in that face-to-face contact. And if we can give that sense off when they're meeting with us, then that will take us a long way. So that's part of acceptance. The next bit is compassion. With compassion, we're focusing on the client's needs or the patient's needs. What is it that they want? Why is it that they're showing up for this visit? How can we be helpful to them today? And it's also promoting the client's welfare. What's going to be beneficial for you? How can I help you make different decisions so that you can be healthier or that you can be in a better situation? And just being compassionate towards that. As for evocation, it's inviting the client's view about barriers to change, reasons to change, possible solutions and pathways to change, and inviting self-exploration. So we want to find out, we can be most helpful as practitioners if we understand what's difficult about changing. What are some of the reasons that our patients or clients want to change or need to change? What are some possible solutions and pathways to change? We might have ideas about what would work, but they may also have some ideas about what would work for them or things that wouldn't work for them so that we can come up with some other options. And then just inviting self-exploration so that we can really understand where they're coming from. And a lot of times if patients feel heard and listened to, this can take us a long way. So what we're going to do next is look at 2 videos. This one is what I consider not so good at using the spirit of MI. But just if you could, just look at just watch the video and think about things that you see that either encourage or don't encourage communication or don't encourage partnership, acceptance, autonomy, and evocation. And it's going to take me a minute to pull this up.
Well, hey, Ms. Clark. My name is Alan Lime. Dr. Seal asked me to talk to you about your drinking.
Oh, okay.
Yeah, he said that you filled out the form and that you came to him for some medication for your stress, but that he was really concerned about your alcohol consumption before he made any prescriptions for you. So let me see that form, please.
Okay.
Thanks. Yeah, well, it says here that you drink 4 more times a week and that you have 1 or 2 drinks and that you go over that limit on a fairly regular basis. That's too much. That's too much. I mean, I imagine that he's already told you that he can't prescribe you anything unless you do something about this drinking.
Okay, I'm really confused. He did want me to come and talk to you. I'm just not real thrilled with the way this is going.
Well, I'm sure you're not, because anybody that drinks at these levels isn't going to be thrilled talking about their drinking with a professional like myself. What we know is that if you continue to drink at this rate, probably going to wind up drinking more and more, and I imagine that's his concerns. You can
I
run into an
didn't think I was drinking that much. I mean,
Well,
one or two glasses of wine
Well, how big
a
is the
night.
glass? I mean, this is a typical glass, which is 5 ounces of wine. But what I know is that most people drink a lot more than that. So
Well,
I'm pretty sure that your glass is bigger than that, wouldn't you say?
you're not in my household. You don't know what I drink.
Yeah,
It's,
I know, but
it's about that size, maybe a little
I've
more.
never been in a house where they have these stem glasses. That's only at restaurants. Most people have tumblers, so I imagine that's what I'd find if I opened your cupboards. Yeah.
No.
Well, anyway, so what he said was that you came to him for some kind of benzodiazepine, something for anxiety, and we can't prescribe anything like that if you're drinking at these levels. So we need you to stop, or at least cut back to reasonable levels, which for you would be no more than 3 drinks in one setting, which you're drinking over that now, or no more than 7 drinks in 1 week, which you are well over right now. So if you can agree to that, then perhaps he can make that prescription for you. I can't promise that either, but that's certainly one thing. The other thing you need to do is to read this, take this pamphlet and read it, and you'll see in there that it tells you about limits of alcohol, and I think you'll find that if you can stick to that, you should be okay. He may be able to prescribe you medication at that point. I'm not sure, I can't promise. But if you do have problems, and I suspect you may have problems coming back to those levels, then we can make a referral for you to a counselor to come and talk about your increased drinking. So, you have any questions for me?
No questions at all.
All right, well, thanks, and I'll tell Dr. Seal that you came in and that you were reasonably compliant and that you said you'd follow through.
You can tell them whatever you want.
All right, thanks.
Okay, so just think about that interaction and some of the things that the practitioner said and the responses that the client felt or what she did that made you just notice how she reacted to some of the things that he said. All right? And our next video.
Well, hi, Ms. Clark. My name is Alan Lime. I'm a social worker at the Family Health Center. Dr. Seal asked me if I would spend some time with you today. I'm really glad that you're here. I'm just curious as to why he would send you to me.
Mm-hmm. Well, I came to see Dr. Seal last week because of increasing stress and anxiety that's kind of getting the best of me. And in the course of my appointment with him, he was asking how I was dealing with that stress. And I mentioned that my 1 or 2 glasses of wine a few nights a week is turning into more frequent and maybe 3 or 4 on some nights.
Okay.
And he had some concerns about that and felt like maybe you could help me with stress or something.
Yeah, so he asked you to see me because you went to him for increased stress, and he's concerned that your alcohol consumption may be a part of that increase. And prior to prescribing you anything, he wanted to make sure that you at least had someone to talk to about that.
I suppose.
Okay. I saw that you filled in one of the pink sheets. May I take a look at that?
Yeah, he told me to fill that out and bring it with me.
Okay, thank you. You say here that you have 4 or more drinks in 1 week. You mentioned that you may be increasing that a little bit as well, and that you have 1 or 2 drinks in one setting.
Typically.
Yeah, and that maybe monthly you have more than that. What kind of drinks do you have? What do you drink when you typically drink?
Wine with my meals. Again, 1 or 2 typically, and more frequently 3 or 4 since my stress has increased.
So it's starting to increase, you're starting to drink a little more. Okay. Well, based on what you put here, it gives you 6 points on this scale. The scale ranges from 0 to 40. So 6 points will put you in what we would consider an at-risk zone. So if it's okay with you, I'll just talk a little bit about that.
Okay.
Okay. So the at-risk zone, as I said, runs 0 to 40. It's not a super high risk, but it certainly could be a risk for maybe increasing stress, maybe some physical ailments related to alcohol as well. Could start to show up if you were to increase your drinking from there, or even stay there. This is a typical standard drink size over here. I'm not sure whether that fits your description of a glass of wine or not.
I filled the glass up, so maybe a little more than
Yeah,
that.
maybe that little space at the top, so perhaps a drink and a half each one. So that will also increase a little bit more. So perhaps maybe drinking more than you indicated on here. And for a woman, healthy woman your age, no more than 3 drinks in one setting is considered to be a lower or no risk, and no more than 7 in 1 week.
7 total in 1 week?
7 total in 1 week. And what you say here is that even on this sheet, you're perhaps already drinking more than that. So what do you make of all that?
That's news to me. I thought red wine with your meals is supposed to be healthy, and no more than 7 in a week. That seems kind of prohibitive.
Yeah, it seems a little less than perhaps you've been drinking or what you consider to be healthy drinking. And certainly there's conflicting information out there about what's healthy and what's not healthy. I imagine the increased stress is what concerned Dr. Seal. As your stress increases, and if he were to prescribe you anything, maybe some interaction between the two that would also be a concern for him, I would think. So if you would, what is it that you like about alcohol?
Well, it does, at least in the moment, temporarily reduce my stress. And I, like a good glass of wine. I don't drink the cheap stuff. I like the expensive.
Right. So you like the taste of it, and it does help to lower the stress, even if it's just for that time you're drinking. What are the not so good things about alcohol for you?
Well, the nights that maybe I have a couple more glasses than I should, I wake up feeling kind of yuck. And, of course, part of my stress is finances, and I mentioned I like the good stuff, and so if I'm drinking more, then I'm increasing my financial burden. So
your financial stress may be increased by the fact that you're drinking.
Yeah, kind of defeating the purpose there.
Catch-22 there, drinking to reduce stress and increasing stress at the same time. So on the one hand it lowers it, and on the other hand it's increasing, kind of the seesaw, teeter-totter effect there. What do you make of that, given that on one hand it lowers, on the other hand it increases, and now it's increasing even more?
And maybe I need to find some other way to deal with my stress.
I imagine you've had some thoughts of that. What have you thought of trying, if anything?
Well, I've exercised in the past, and that helps. Right now my schedule is kind of out of whack, and I just really don't know what to do. That's why I came to see Dr. Seal. I thought maybe he could prescribe me something that would help me, when I'm feeling overwhelmed.
And he may be able to. I'm not saying that he cannot. I'm just imagine that he's concerned that if you continue to drink on the level that you are drinking, that whatever he prescribes you, there may be an interaction with the two. I imagine that's his concern. I'm not completely sure. So you've had some success in the past with changing behaviors, and if you were to decide to make any changes here, it sounds like you could draw upon that to make those changes. How important would it be for you on a scale of 0 through 10? I have a little kind of visual here of that. If 0 is not important, 10 is very important, to do something about your drinking right now.
Well, I mean, if it means that it's increasing my stress, or he's not going to prescribe me anything because of my drinking, then it's fairly important, maybe about a 7.
That's pretty up there. Why did you choose a 7, not a 5 or a 4?
Well, again, I've got to get things under control. My kids are dependent on me, and I've got to go to work to help ease this financial stress, and so, all those responsibilities.
So there's a lot riding on your decision here on what to do with this. What, if anything, will bring it up to an 8 or 9 on that scale?
Well, the risk that you mentioned about the drug interaction, I certainly can't afford to, have any more stress. So.
Yeah. So you choose to lower your stress rather than increase it, and if lowering your drinking would have that effect, that's something you'd be willing to do right now. How confident are you that you could do something about your drinking?
I'm pretty confident. Probably about a 7 or an 8.
Okay, so it's pretty high up there again. And what if anything would you choose to do? Would it be to cut down? Would it be to quit? I'm just curious about that.
Like I said, I like a good glass of wine. I don't want to quit altogether. I'd be willing to try cutting back. But now, if Dr. Seal would agree to prescribe me something for the anxiety, and it meant that I had to not drink at all, I'd be willing to do that at least for a period of time.
So you'd be willing to stop altogether if that's what was indicated by the physician. Okay. So based on that, how ready are you to do anything right now, whether it's to cut back, whether it's to quit?
Well, again, if I can get something to help me manage, if maybe I can find some other way to deal with the stress, then I'd be pretty ready. Again, maybe about on that scale, maybe an 8.
Okay, so that's pretty high up there as well. It sounds as though you're pretty motivated to do something about this right now, given your responsibilities, given your children relying on you at this point, and just on lowering your anxiety in general. It sounds like that's one of your goals as well. Well, I'm pretty confident that once you decide to do whatever it is you decide to do, you'll be able to follow through with that based on your experience in the past of making behavior changes. I imagine there's some things that you can draw upon. What's one thing that you could do? I imagine you thought of some things that might help to lower your stress.
Well, the exercise, but again, that's kind of difficult to fit in right now. Hoping that Dr. Seal will prescribe something for me to take when I'm feeling particularly overwhelmed, and maybe just having somebody to talk to bounce some things off of.
One of the things we can offer here is for you to come in and talk to one of our behavioral health specialists. May be able to help you talk through this area of your life, this area of increased stress, and sound like responsibility there. And we can make an appointment for you if you like before you leave today. Talk to somebody.
That'd be nice.
Great. It also has some information here if you're interested. A pamphlet on alcohol and what healthy limits are and how it may be affected by medications that you take as well.
Okay.
And I wish you lots of luck. It sounds as though you're really committed to making this shift and this change. And I imagine Dr. Seal will want to follow up with you and see how you do with your change within a few weeks.
Okay.
And again, I look forward to speaking to you in the future.
All right. Thank you very much.
You're very welcome.
Doctors, nurses, and physician assistants
Sorry.
all have opportunities to counsel patients.
Okay, so now we've seen 2 different videos. If you think about, again, some of the things that the practitioner did differently in the second video than the first, and what things, we talked about the spirit of MI, the partnership, acceptance, autonomy, and compassion. What kinds of and evocation, what kinds of things did you notice that were different in the second versus the first video, as well as the patient's response to what the practitioner said in both videos? I'll just give you a couple minutes to just think about that a little bit. What was good about that, what wasn't good about that. So when we think about the not so good examples, in the first video, as I'm sure some of you remember, there's a lot of wrestling. Alan Lyme sort of comes back and says, I'm sure you're not, really thrilled about this, because anybody who drinks at these levels isn't going to be thrilled about talking about their drinking with a professional like myself. So that already puts the person at, on defensive about, this is not something I want to do. This is not where I want to be. Versus when the second example, they were more like dancing, so they were more in partnership. He asked what her thoughts were. He never took an authoritarian stance and said, you need to do this, in a way that was condescending. Also, some differences were, directing versus autonomy. In the first video, he was very sort of punitive, like, oh, your doc can't prescribe anything unless you do something about this drinking, versus, letting you know, it's choice. She had a choice. It sounds like you're pretty motivated to do something about this right now. He asked questions and gave reflections based on what she said that let her know that he was listening to her, but also trying to figure out where she was coming from and what things were like for her. Another difference was that he was much more detached, and it was like, oh, here, through this pamphlet, or you need to read this and stick to it, versus letting, showing compassion and, saying things like, there's a lot riding on your decision on what to do with this right now. I really feel confident in your ability to do this once you make a decision. And then lastly, in the first video versus the second, there was advocating versus evoking. So he was saying you need to stop this or cut back, at least to reasonable levels, blah, blah, blah. Versus the second time when he's like, well, what do you like about alcohol? What are not so good things about alcohol? So again, asking questions that give us a sense about what it is that is going on for her, so that he could either word things or suggest things that might make more sense, versus just saying, here, read this pamphlet and do this, or you're not going to have this happen. I'm sure the response that she gave, behaviorally you could see it, sort of physically she turned around, she didn't look at him, she had her arms crossed. She was very angry with some of the things that he was saying in the first video, versus her more openness to talk during the second video. She talked more openly and more freely in the second video, just based on what the doc was saying, or the social worker was saying, because of the way he asked questions and the way that he made statements to her responses, which was very different than the first. And these are some of the things that we're looking at when we think about the spirit of motivational interviewing. When we think about styles of communications, there's there's about 3 of them. So there's following, guiding, and directing. If you think about a situation that you might be in, like maybe a lecture setting, where you have someone who's directing, they're spending a lot of time informing, which is that taller line in the first column, and maybe half the time asking. Then there's really very little listening going on because someone is doing all the talking, or most of the talking. And then when we think about following, maybe when you're having a session with one of your friends, there might be some little informing, some asking questions, and much more listening. So if someone comes to you and says, oh my goodness, I had the worst day, that person might then just be talking, and you are listening and maybe asking some questions intermittently, but not doing very much informing. And then when we think about maybe guiding, which is more of the MI style, there's an equal amount of informing, asking, and listening. So, and this doesn't mean that any one communication style is better than the other. This is just that there are differences. And when we think about motivational interviewing in some of these settings, we want to think more about a guiding approach versus directing and following. So I have a quick example of directing, and these are a little bit shorter. Oops.
Patient counseling regarding various products that are available to patients, both over-the-counter and by prescription. Many patients who are speaking to you will be interested in improving their health, though some may not be prepared for the behavioral changes that are required to do so. This can be
Can I help you?
Yeah. I just got off work and apparently they're going smoke-free, so I thought I'd stop by the pharmacy here and see what my options are. Some of my friends have tried nicotine patches and they say they don't work very well. I don't really want to quit smoking. I just need something to get me through the day.
So you want nicotine replacement, but you don't want to quit smoking?
Maybe like during the day nicotine replacement. Is that, do y'all have anything like that?
Yeah, we don't really recommend that. The idea is you would use the nicotine replacement to actually quit. So then you wouldn't be smoking at work, but you also wouldn't be smoking the rest of the time either.
Well, I don't really want to quit. I like smoking. I'll go after work to have a beer with my friends and I'll smoke cigarettes. It's not really a big deal. Cigarettes aren't that bad. I know that it's popular to say that smoking is bad for you, but I like it, so I'm going to keep doing it.
Okay, well, smoking really is really bad for you. It causes things like lung cancer, emphysema, heart disease, oral diseases.
Well, what are my options, assuming that I'm right, what are my options?
Well, to be honest with you, you mentioned the patch. I can't recommend a patch to you if you're going to continue smoking. That can actually be pretty dangerous for you. In order to advise you about this at all, I need you to tell me a little bit more about your smoking history and how much you're smoking now.
But I mean, I smoke barely a pack a day. I mean, I've probably smoked about 5 or 6 years now. It's not really a lot of cigarettes, but it's sort of hard to get through the day at work.
Okay, well, we actually consider 20 cigarettes a day to be a significant amount, and in fact, I would then recommend to you that you would start on the highest dose of nicotine replacement.
Sounds good to me. The more nicotine, the better. Is there like gum or something? I could chew it like while I'm in the office. That sounds pretty great. I mean, do you have?
There are some products that you could use to take away some of your cravings, and probably the gum would be the best option for you. It's not something you would continue to use continuously throughout the day, however. The gum is something you use just when you have a craving.
Oh, okay. Well, where's that?
Well, we have that here, but again, the idea would be for you to actually quit smoking.
Well, I'm probably not going to buy anything today. I mean, I just came by to see what my options are. Thanks for the input. I mean, do you have anything else? Do you have any other advice for me?
Aside from the gum, you could try the nicotine lozenge. That would be another option for you. Again, that's not something you'd want to use continuously throughout the day. The nicotine patch is the best for continuous nicotine replacement, but again, that's not something you can use while you're continuing to smoke.
Oh, well, okay. Well, thanks. I mean, I guess that helps a little bit. Maybe I'll be back later. Thanks.
Okay.
Okay, so that was more a directing approach. This next one is more guiding.
Happens.
Hi, can I help you?
Yeah, I hope so. My workplace has just gone smoke-free. I'm not very happy about it. I'm going to keep smoking, but I was wondering if there's anything that can help me like get through the day, so I can, go get my beer and smoke cigarettes after work.
So your workplace just went smoke-free and you're not too pleased, huh?
No, I'm not going to quit smoking. I mean, I like it. It helps me relax. So I mean, I don't see what the big deal is.
Okay. Tell me a little bit about how smoking fits in your day. It'll help with the
I mean, I smoke a little less than a pack a day. It's not too bad. I've probably smoked for the last 5 years. But I mean, I could quit if I wanted to, but I don't really want to right now.
Okay, so you feel like right now smoking is a pretty important part of your life. It's not something you're ready to change, but if the time came when you did decide to quit, you feel pretty confident that you could go ahead and do that.
Sure, I could quit.
Okay, what makes you so confident?
Well, I mean, I don't see why I couldn't. Although I have not ever tried to quit. It's just something that I do for fun, on breaks at work, in the morning, and after work.
Mm-hmm. And so, in terms of a readiness to actually go ahead and make a quit attempt, where do you think you fall on the scale of 1 to 10, where 1 is, I'm not considering it at all, and 10 is, I'm definitely ready, I want to quit?
I'm probably 2. I haven't even thought about quitting until this great announcement at work today. I'm totally not going to quit smoking.
Okay. What made you say 2 instead of 1?
Well, I mean, anything's possible. I mean, I guess I could maybe be convinced.
Okay.
Is there are there things I can try that would make me, want to quit smoking?
Well, there are a lot of products available now that can actually help you curb that urge to smoke. We have products that can help to replace nicotine, which can help to decrease withdrawal symptoms that you might experience when quitting or cutting down, and also some medications that your doctor could prescribe for you that might take away even some of the desire to smoke.
Okay, well, that's good information. I mean, I'm not going to do anything today. I just need to know my options. But that's encouraging. If I decided to quit smoking, I do have at least tools to help me quit.
Sure. And back to that scale you mentioned, you said you were a 2. What do you think it would take to move you up to a 4 or a 5?
I don't know. I guess if my friends, if one of my friends decided to, quit with me, that would probably help too. But all my friends love to smoke, so I don't see that happening in the near future.
Sure. I wonder if now that your workplace is going smoke-free, if there will be some people at work who are planning to quit.
That's a good point. I hadn't really thought about that. That's a good idea, yeah.
Okay. Well, it sounds like you're really here just for information today. I'm happy to help you pick out some of these products if and when you decide that the time is right for you.
Okay, well, thanks a lot.
This time, the provider attempted to counsel the patient regarding
All right. So just think about the differences. The first one was more directing. You need to quit. You need to do this. This is why. Versus the second one where the practitioner was more like, tell me more about what's going on. What do you like about smoking? What do you make of this? Which is a very different approach. And both of those clips took about the same amount of time. And one thing that I found interesting is that the guy walks in not having any thought about even thinking about quitting, just how to get through his workday. And in the second video, he was, even thinking about, oh, there might be possibility, there might be something that comes up that would cause me to quit. Whereas in the first video, that wasn't even there. He's like, I'm not quitting, you can't make me, and that's, there's no discussion. So just even the way that we say things and how we phrase questions can turn an interaction, can make a difference in an interaction. So thank you for watching those. And just conclusions for sort of this particular module is just to give you a sense that behavior change is hard. When we think about our own behavior change, we think about our own things that we want to do that's different in our, that making any change can be hard. And so for our patients and our clients, and we're asking them to do things that might be increasingly difficult, that's hard for them too, and being a little bit compassionate towards that. We also learned that MI Spirit is the MI Spirit to promote behavior change includes partnership, acceptance, compassion, and evocation. And one thing I just wanted to add is that acceptance is also a bit of recognizing that the patient or the client makes their own decision, even if it's something that we don't want them to do. So even if they choose not to take this medicine, we have to accept that this is where they are. It doesn't mean the conversation ends, and it doesn't mean that, oh, this is a great idea, keep going out and smoking or keep going out and doing heroin, but it means that this is where they are right now. And for us as practitioners to accept that this is where they are, that can be helpful. And then we can ask patients, well, what is it that you like about it, or what is it that, and then, we can ask questions about, well, what are some not so good things about it? That leads us to more discussion, but accepting where someone is, I think, vitally important to accepting that person in front of you for who they are. And then another thing about promoting behavior change with a guiding style by balancing, listening, asking, and informing, like that last graph with the different communication styles, can be helpful. Now, again, this doesn't mean that you do this all the time with everybody, but there may be sections of an interaction that you have with someone that is more MI-based that would yield more language and verbiage towards behavior change, but also creating an environment where someone feels heard, listened to, and valued. And that's what I think the MI Spirit does particularly well. Thanks.